A venous thromboembolism, or VTE, is a condition that comprises deep vein thrombosis, or DVT, which is a thrombus in a deep vein, usually in the leg, and a pulmonary embolism, or PE, which is the blockage of a lung artery by an embolus. The most common type of VTE is a DVT. DVTs predominantly occur in the large veins of the leg. When part or all of a thrombus breaks away from the blood vessel wall, it travels in the direction of blood flow towards the lungs. The thrombus is now called an embolus. The embolus can block one of the arteries in the lung. This is called a pulmonary embolism, or PE. Patients with DVT are at risk of PE, which can potentially be life-threatening. Venous thromboembolic disease is a major problem worldwide. A study by Kahn et al. In 2013 identified the formation of a VTE as the most common preventable adverse event and/or cause of death for hospitalized patients. This same study indicated that VTE is 100 times more likely to occur in the hospital setting than in the community, with a 50% greater likelihood in patient groups undergoing care for strokes, elective hip replacement, trauma, and total knee replacement. In 2014, New South Wales Health reported that in Australia, there are over 14,000 cases and 5,000 deaths linked to VTE annually. In addition to VTE being a preventable medical occurrence, a study by Collins et al. 2010 showed that the complications from VTE could lead to an increase in length of hospitalization, an increase in healthcare costs, long-term disability, and even death. This same study estimated the financial burden of preventable VTE to Australia to be over $1.7 billion. In 2013, a Cochrane systematic study ranked the prevention of VTEs number 1 out of 79 strategies in need of further modification to increase the safety of patients while in the hospital setting. VTE is typically associated with surgery, trauma, and cancer. Predisposing risk factors for VTE include increasing age, particularly greater than 60 years, pregnancy, obesity, immobility, including lower extremity paralysis, a personal or family history of VTE, dehydration, use of estrogen-containing oral contraceptives, and use of hormone replacement therapy. Acute triggering events include surgery, active cancer and cancer treatment, respiratory or heart failure, acute medical illness, critical care admission, stroke, central venous catheterization, varicose veins with associated phlebitis, and long-distance travel. Idiopathic cases occur when a patient has no clear exposing risk factor or triggering event. In 2014, the VTE prevention program was launched to reduce the incidence of hospital-associated VTE in New South Wales public hospitals. The aim is to ensure that all patients are assessed for VTE risk and given the proper prophylaxis. The Clinical Excellence Commission developed a framework for the prevention of venous thromboembolism. This framework was designed to assist in the guidance of local health districts and facilities in the implementation of the Prevention of Venous Thromboembolism Policy Directive. It assists local health districts in identifying at-risk patients, promptly assessing them, considering risk versus benefit of treatment, prescribing appropriate prophylaxis, engaging and educating the patient in their care, regularly reassessing the patient, and monitoring the hospital's performance in an effort to continually improve practice. Prophylaxis should be started as soon as possible during the patient's admission or immediately following the risk assessment. There are 2 types of prophylaxis: pharmacological, such as enoxaparin or heparin, and mechanical, such as anti-embolic stockings. Despite the well-recognized risks of VTE, a 2016 study by Asare et al. Found the use of appropriate prophylaxis remains low. A written order must be made once the decision has been made to prescribe either or both pharmacological or mechanical prophylaxis. This must be filled out in the VTE section of the National Inpatient Medication Chart. Surgery is a major risk factor for VTE, especially major orthopedic surgery such as elective hip or knee replacement surgery, hip fracture surgery. This is due to hypercoagulability caused by trauma or surgery. Without thromboprophylaxis, the incidence of DVT is 40 to 60% after elective hip or knee replacement surgery and is as high as 60% after hip fracture surgery. Without thromboprophylaxis, the incidence of DVT after general surgery is 15 to 30%. The risk of a PE is approximately 0.08%. Duration of hospitalization and type of surgery affect thrombosis risk, with major gynecological surgery posing a VTE risk similar to that of general abdominal surgery of 15 to 40% without preventive therapy. The risk of VTE after major surgery persists after discharge, with patients being at risk of late onset VTE for up to 35 days post-surgical procedure. Therefore, extended duration of thromboprophylaxis is recommended. In 2008, the World Health Organization recognized a challenge in the area of improving patient outcomes in the surgical environment. A system-wide infrastructure to safer surgical care was desired. The World Health Organization noted that no single remedy to improving surgical safety existed, and that a sequence of necessary steps in care was called for where the entire multidisciplinary healthcare team could work together to provide better patient outcomes. Out of this arose the Surgical Safety Checklist, which has been further modified by the surgical and nursing governing bodies of Australia and New Zealand to include: has thromboprophylaxis been ordered, to the middle column of the timeout checklist. Morbidity from VTE occurs before the implementation of treatment. Therefore, prevention of VTE is the best way forward. The education and empowerment of nurses in regards to VTE prevention will enable nurses to play a key role in decreasing the incidence of VTE. A recent study by Collins et al. 2010 showed that an increase in knowledge regarding VTE prevention led directly to a decrease in their formation and improvement in patient care. The same study identified the nurses of Australia as being well positioned to be on the forefront of changing the culture of the hospital environment in regards to VTE prophylactic care, leading to shorter length of stay, decreased healthcare costs, and reducing avoidable patient morbidity and mortality.